Good evening, everyone, and welcome to NOCC's Summer Digital Learning Series. I'm Alana Feuchter, Patient Insights and Advocacy Advisor. Tonight, we embark on our third session in this series, and hopefully some of you have had the opportunity to join us as we addressed nutrition and art. If you didn't and you are interested, you can always watch the replays on NOCC's YouTube channel. Before we begin with tonight's session on sleep, a topic so many of us have been anxiously awaiting, I'd like to take a few minutes and discuss a few housekeeping items. First, a thank you to our sponsors, AstraZeneca, Merck, and Foundation Medicine. Second, I wanted to let everyone know that we are recording this session in speaker view for later viewing, so we can put them on the YouTube as well. But we will stop recording after Dr. Gonzalez finishes his presentation, but before we have the questions from you answered. As we are a large group, we ask that you type the questions that you have in the chat function at any time during the presentation. And we do have time at the end, and we'll hopefully get as many questions answered as we can. And finally, if you aren't already on mute, it looks like most people are, please do so just so we can give Dr. Gonzalez our full attention. Now, tonight's speaker, Dr. Brian Gonzalez, joins us from the Moffitt Cancer Center in Tampa, where he is a postdoctoral fellow in behavioral oncology. Dr. Gonzalez's research focuses on identifying which survivors are at greatest risk for quality of life issues. He works with multidisciplinary teams to develop culturally targeted interventions to improve quality of life using inexpensive and accessible strategies. Tonight, he will share ideas for improved sleep, which we all know is critical to the healing process. Welcome, Dr. Gonzalez.
Thank you for having me. Thank you for this opportunity. I'm looking forward to describing ways to improve sleep for healing. It's a critically important component of the healing process. And I'm eager to continue the research that I do in this topic at Moffitt Cancer Center, where I'm currently an associate member. And I'm happy to present to you all today. And then looking forward to taking questions. This is a topic that a lot of people care deeply about, and I'm eager to see what your questions are and address those that I can. It's a common issue, insomnia, or difficulty sleeping for most nights for several consecutive months. That's kind of a common definition for insomnia. It's a common issue among ovarian cancer survivors. Around the time of diagnosis or soon afterward, about 39% or so of ovarian cancer survivors are dealing with insomnia. And that drops significantly after about 6 months after diagnosis. But it seems to be stable and maybe increase a little bit in kind of the medium to long term, so that we're by 3 years after diagnosis, there's still about 30-something% of patients who are dealing with symptoms of insomnia. That's a pretty high rate. It's higher than the general population, where fewer than 20% or so at any given time are dealing with symptoms of insomnia. And there are also some disparities. So one of the approaches that I'm taking nowadays is to focus on how to reduce disparities or differences we see in issues like insomnia and other quality of life issues among minority or racial ethnic minority populations or other underserved populations like rural patients, for example. Among AfricanAmerican cancer survivors, we see about 57% or even higher than in the other population we saw dealing with symptoms of insomnia. And that's staying, again, pretty stable or increasing over time, so that about 2 years later, they're dealing with 61% are dealing with insomnia symptoms. And then there are many definitions for what constitutes short sleep, meaning sleeping too little overnight. One of the definitions is sleeping fewer than 7 hours per night. Again, there are high rates of African-American cancer survivors dealing with short sleep from before, during, or after the diagnosis and the treatment period. In that particular study, a study of mine recently, this is again among African-American cancer survivors, we split these patients into two groups. The one group of patients that had significant sleep disturbance at baseline. They had insomnia symptoms. They were having trouble sleeping around the time they were diagnosed. So that is pre-diagnosis, all of them had significant sleep disturbance. And in blue here, you see that about 60% of them went on to continuously have sleep troubles 10 months and 24 months after their diagnosis. And there are other groups that kind of, for whom insomnia came and went. But basically the majority, that is about 78% of them, had significant insomnia symptoms about 2 years after their diagnosis. Conversely, there's a different group of patients who had good sleep. So they did not have significant sleep disturbance at baseline or around the time of diagnosis. And even them, in that group, about 40% of them had significant insomnia symptoms 2 years later. So it's something that is common around the time of diagnosis, and it also is something that develops over time in a lot of cancer survivors, particularly among racial ethnic minority groups. And so what do we do about it? It's important for one's well-being, it's important for one's healing, and it's important for the way one feels. But what do we do about it? So there are lots of ways to intervene on insomnia. There are relaxation strategies, there's sleep restriction, cognitive therapy, combined cognitive and behavioral therapy, and mindfulness-based therapy for insomnia. We'll describe each of these in turn. But let's start with the most common treatment for insomnia, which is medication. So sedative medications, common medications include things like Ambien, for example. Many times these are prescribed, sometimes they're not, sometimes they're over-the-counter medications that are used to help people sleep better. Sometimes they're not really intended for sleep, like Benadryl, but they're used that way still. And then there are others that are intended for sleep, and then but those are over-the-counter meds. There are, however, many that are prescribed for sleep, and these sedative medications are pretty helpful. They're most common in the primary care and oncology settings, and they're most helpful for transient symptoms of insomnia. So this is an issue that came up recently and has only been around for maybe weeks to only a couple months. That's a really good use for something like a medication to help somebody kind of re-normalize their sleep pattern and improve and reduce their insomnia. That's what it's tested for, and that's what it's particularly good for. If it's a chronic insomnia issue, where insomnia has been something that someone has been dealing with for months and months or years, then it's less helpful, because long-term use can lead to, it doesn't always, but in some cases and in some medications, it can lead to tolerance or dependence and results in side effects of these medications. It doesn't really solve the underlying behavioral problem that's causing the issues of insomnia. And sadly, the result is that insomnia often recurs in patients taking medications to help improve their sleep. So there's this timeline that's kind of commonly used in the insomnia research groups, where we have patients in 3 different time ranges. This is the time before they develop insomnia symptoms. This is around the time they develop some acute issue that in the short term is causing insomnia. And that could be anything from having been into a car accident, or dealing with something very stressful like a divorce, or some major medical illness like cancer. Lots and lots of things can be stressful, and in the short term can cause insomnia symptoms. And then there's this longer term follow-up period after that acute issue goes away, or one has learned to deal with it, or it's no longer an acute stressor. And then on this y-axis here, we can consider the amount of insomnia, the severity of one's insomnia. And the higher it goes, the worse it is. And every single person in this presentation, myself included, has some severity of insomnia at baseline, right? We don't all have no symptoms at all of insomnia. We don't all sleep perfectly well. But that doesn't mean that we all have enough to consider ourselves having significant insomnia. So those of us who rise up to or above that magic line of having significant insomnia, those are people who are diagnosed with insomnia. So in the lower levels, there are folks who, before any acute issue, have some level of insomnia symptoms, and that persists over time, and it stays with them throughout their life cycle. But in the short term, when that acute issue arises, their insomnia symptoms shoot up. And they have a lot of insomnia, and they have a really hard time sleeping. They may not sleep for a couple of days, or they may have trouble sleeping for weeks and weeks at a time because of this short-term issue. But for most people, that short-term issue goes away, and maybe there's some lingering effects of it in the long term. And so maybe they have a little bit worse sleep, but in the longer term, they've returned to their normal sleep patterns. They've returned to their normal sleep habits. They generally don't have insomnia, and that happens for most people. So again, think of all the times that you might have in the past had some very stressful, significant situation that might have impacted your sleep in the short term. In the longer term, for many and most patients, that issue will go away. However, for some people, they have these maladaptive or counterproductive behavioral patterns that one gets into that makes it hard to continue without having insomnia symptoms. That is, after the insomnia symptoms go away, after this blue stuff from that short-term stressor goes away, this red stuff emerges, which are these counterproductive behaviors that make it harder to sleep well. Some examples include, I'm having trouble sleeping because of some short-term stressor, and I'm having trouble sleeping all week. And then finally Saturday comes around and I decide to sleep in all day, most of the morning into the afternoon on Saturday to catch up on some sleep. Or I'm trying to nap as soon as I get home from work. That may seem logical in the short term, but kind of in the longer term, that can lead to counterproductive, it can be counterproductive and lead to insomnia symptoms. Compound on top of that, cancer-related factors. Those can include such issues as worry that my cancer is going to return for cancer survivors. There may be side effects of cancer treatment. So there may be lots of stressors and physical symptoms that might contribute to insomnia in the longer term, in addition to what normally occurs in people who don't have a history of cancer. So in terms of the treatments, based on that theory, the treatments are kind of based on what we see from that theory on how insomnia develops. And thinking that there are a couple things that contribute to insomnia. One of them is arousal. That is kind of physiologically and mentally being kind of aroused and being awake and alert at a time when you're trying to be sleeping in bed. And there are a couple things that can contribute to that. That is poor sleep hygiene. Conditioned arousal means that we're tired on the couch, tired all day maybe, finally make it to the bed, and suddenly we're alert and aroused. And that often is the result of the stress and frustration of being in bed for many, many nights, for long, long hours, awake, and being angry about it, in pain, and distressed about it. In bed can cause one to be conditioned or learn that this is a stressful place to be. Whereas for most people who don't have insomnia, they have the opposite, where they get in bed and they kind of feel drowsy because this is what they've conditioned themselves to be as a sleepy in bed. There are also some habits that we can develop from before bed or during the time that we're in bed that can be counterproductive in terms of being arousing. So that's one of the issues that can cause arousal. And so to address this arousal that people feel in the moment as they're in bed or about to get in bed, we provide relaxation treatment. And that can take many forms. Those could be guided imagery. So you might hear an audio sample, or you can look up on YouTube. There are lots of ways to get a hold of guided imagery audio files where somebody's kind of walking you through, and you sit in a comfortable place and you close your eyes and they kind of talk you through an imaginary experience of being at a very pleasant beach or some kind of cool water setting or relaxing scene. That kind of relaxation strategy can help if you learn it outside of bed and then practice it outside of bed. Once that has been learned and has become kind of routine and something that you can do pretty well and helps you relax, then apply it in the bedroom. In bed would be a useful strategy. Meditation helps too, in the same way. Progressive muscle relaxation is another, where one is asked to tense up really tightly and then relax very deliberately each of the various muscle groups throughout your body, from your toes all the way to your forehead. And that helps too for relaxation purposes. There's also virtual reality relaxation that I'm working on in some of my research at Moffitt Cancer Center. And I'll show you an example here, where patients might be asked to wear various headsets or devices. Some of them for video game purposes can be kind of clunky and require a lot of wires, but there are others that don't require that kind of stuff that can just use a battery and be much easier to use. Onto these devices, we're putting on an app or an experience that patients can use to help learn some of these relaxation strategies. Again, outside of bed, practice them outside of the bed, learn them outside of bed, become good at it over the course of a couple of weeks or months, and then apply them in the bedroom is the idea. So here's a brief video. You may be able to hear it. And so patients would go through the settings and choose which of the videos they might like to experience first. Each of them are beach scenes. They might want to not hear any audio as we're using in this demo. They might want to hear some music, they might not. They might want to choose different music settings. So the idea with that virtual reality training is that rather than talking you into imagining that you're in one of these relaxing settings that can help you relax, we might actually put you in one of those settings using virtual reality. And so that's what we look forward to testing in the near future in some of our research here. In addition to relaxation, mostly to treat that arousal in bed, there is something called sleep restriction that is focused on addressing these two contributors to insomnia. On the one hand, there's a disruption in your sleep drive. That is kind of a sleep hunger. So imagine that you had a routine for actual food that you ate every day at 8 a.m. and at noon and at 6 p.m. And you ate that way, the same meal every day. Ignore the fact that it might be boring for a while, but the same exact meal at the same exact time of day, every day for years and years and years. And then suddenly one day, you have your breakfast as usual at 8 a.m. Then you have your lunch, but instead of at noon, you don't wait till then, you have a huge snack at 11:45 a.m., right? 15 minutes before you're about to have lunch. You have a huge snack at 11:45, you eat it really quickly, and then 11:55 rolls around, and finally noon rolls around. Are you gonna be hungry? The answer is no, because you had a huge meal at 11:45. Your body doesn't really care what time it is in terms of hunger. The fact that you had that huge meal trumps the fact that you normally eat at noon, right? And so it's kind of a hunger is something that kind of builds up over time. And if you snack or eat a meal, you're going to reduce that hunger. And so your sleep drive is kind of like that too. It's only based on how long ago you slept and how well you slept. So if you slept pretty well last night, or even moderately well, but it's the morning, you're not going to be so sleepy. But over time, you get hungrier and hungrier for sleep, or your sleep drive increases over time. And so what happens is we can accidentally disrupt our sleep drive by taking naps, like I mentioned. So let's say I'm having trouble sleeping for a couple of days in a row, and finally, Thursday afternoon rolls around, and I get home from work a little early, and I take a 3 or 4 hour nap in the afternoon, once I get home from work, let's say at 5 p.m. Well, if I've done that, what I've actually done is taken a meal or snacked on sleep, which means that I'm no longer hungry for sleep at my usual bedtime. And so that's one way that we can disrupt our sleep drive. The other issue is circadian dysregulation. And so you might have heard of your circadian clock or your internal body clock that does know what time it is. And that's based on lots of inputs and lots of ways to it doesn't really know what the clock says, but it knows how long it's been outside of your normal 24-hour rhythm, right? And so typically it causes you to be sleepy through the day, or it causes you to be less alert as the day goes on. And especially around the time you're supposed to be, based on your schedule, would be going to bed. And so with that, the circadian rhythm kind of helps make it easier for you to fall asleep around bedtime. However, if it's dysregulated, if the schedule is kind of thrown off, if you've caused the jet lag accidentally, even within your own time zone without flying anywhere at all, we can cause that kind of jet lag by scheduling our sleep to vary through the week. So if on Monday through Friday you have a certain sleep schedule, and then on Saturday and Sunday you have a different sleep schedule, that can dysregulate your circadian rhythm or your body clock. And that makes it hard to stay asleep when you want to stay asleep or fall asleep or wake up on time on Monday morning when you're adjusting your schedule again. And so for those two issues, we often provide sleep restriction as a treatment. And basically it's estimating the amount of time, trying to make sure that the amount of time that you spend in bed is about the same amount of time as what you truly need for sleep. So the goal is to improve your sleep efficiency. And the way we do that, the sleep efficiency, very briefly, is the percentage of time that is spent in bed that is actually spent asleep. So if you spent 8 hours in bed, but only 4 of those hours were spent sleeping, then that's a 50% efficiency, sleep efficiency. And that's pretty low. If you spent, 6 hours in bed, but only 3 of those hours were spent sleeping, again, 50% sleep efficiency, and that's lower than we like. It's usually got to be, ideally, it's more like 85% to 90%. And the way that we do that is we ask patients to complete a sleep diary. That is, every night, or every morning, excuse me, they're asked to write down what time you got in bed last night, what time did you start beginning to try to go to sleep. Those are 2 different times, right? Just because you got in bed, especially these days with cell phones and iPads and TV in bedrooms, doesn't mean that you began trying to fall asleep at that same time. So those are two different questions. The time they got in bed, the time they began trying to fall asleep, how long it took to fall asleep, et cetera, and all of that to estimate, in this example I've given here, how much time was spent in bed, 10 hours, how much time was awake at night, was 4 hours, so you have to subtract that, so now we've only got 6 hours spent sleeping. There was also some time spent napping in the daytime, so 2 hours, for a total of 8 hours spent sleeping each day total, including nap time during the afternoon. And so the total time of sleep, somebody would do the math, adds up to 56 hours for the week. That's about 8 hours on average for the day. That's pretty obvious in this example. It's very uniform. And so what we do when we're providing sleep restriction therapy is we say, why don't we just add a half hour? Because ideally it might take you, in a normal person in a normal circumstance who does not have insomnia, might even take 5, 10, even 15 minutes to fall asleep. And might kind of take 5, 10 minutes, 15 minutes even to wake up gradually in the morning. And so that's why we add those together into a half hour add-on before and after sleep. So we say this person needs about 8 hours of sleep per day. Let's ask that person to spend 8.5 hours in bed overnight, and no more and no less. And so we set the rising time for this person based on their morning routine. So we'd say, if you have to be out of bed by 8 a.m. to get to work, then we have to subtract 8.5 hours from that, and we have to get you in bed by 11:30 p.m., for example. We'd set the bedtime that way, and then we just adjust during the course of therapy over time to make sure that the sleep efficiency gets back to 85 to 90%, which is optimal. This is over the course of weeks and weeks of therapy with a therapist, usually one. Another therapy that we provide is something called cognitive restructuring. This is to help individuals for whom there is a lot of anxiety around bedtime or around the time that one is planning to go to bed. And so there are a lot of maladaptive thoughts and often incorrect thoughts of many people, especially people with insomnia, might start thinking to themselves around sleep. And so an example here is, I'm always groggy when I get up because of my insomnia, which may be a way of actually accidentally misattributing the grogginess to one's insomnia. Lots of people are groggy when they wake up in the morning, and may be unrelated to insomnia. Patients might think to themselves, well, I didn't sleep at all last night. When in reality, that's very, 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 very rare. It's not enough, maybe, and maybe it's not as much as you'd like, but it's not all or none, the way that we might sometimes think. We might also catastrophize. We might say, if I'm tired at work tomorrow because of my insomnia, I'm going to be sleepy during my meeting, and I'm going to get noticed, and my boss is going to fire me. And those kinds of issues can be distressing and can accidentally cause additional distress around bedtime and being in bed. The way that we overcome these maladaptive thoughts is by doing something called cognitive restructuring, where we ask patients to complete this log, where we have patients talk through an example where we help patients think through incidences in where they experienced a lot of distress around sleep, for example, but it's commonly used in the context of outside the context of sleep, but some distress around sleep, and then we ask them to describe what the way they're feeling is, also describe their situation, so what was happening around that situation, and then we ask them to think through some of the negative self-talk that might occur. So what was I thinking just before I felt this mood? And then maybe ask to inquire about whether they're making a thinking error, one of those errors that we were describing a moment ago that we've labeled here. Sometimes the answer is no, but often the answer is yes. And so we ask them to kind of think through some of the evidence about whether this is true or untrue. Is there some kind of alternative, better, more balanced way to think about this issue, and how that might be helpful. Another issue to help with anxiety that might be contributing to insomnia is something called worry scheduling. And in this cartoon here, you can see the person saying, you worry too much and it doesn't do you any good. And the patient saying, well, it does for me. 95% of the things I worry about never happen. And that's not really how it works, right? And so what we do in worry scheduling is ask participants to write the problems that they think might likely keep them awake. What is it that keeps you awake at night? What is it that wakes you up in the morning? Write down then the next step to solving that issue. Take a moment. This is outside of bed. This is hours before one gets in bed. Think through what is the next thing, not the whole chain of events to fix the problem, but the next thing you could do tomorrow, perhaps. Maybe the whole solution is the next step. Maybe it's just you decide to yourself, well, this isn't really a big problem. I don't really need to think of this through. You might think it could be as simple as just asking someone else for help. That may just be the next step. Or that's the next step. And you repeat that for all these concerns that you think might be likely to keep you awake at night. And then you fold this paper in half and you leave it on your nightstand and try to remember, if you find yourself worrying, either when you're trying to fall asleep or if you wake up in the nighttime, and remember, you already have steps you've written down to take in the morning. There's nothing you can do now at 2 a.m. Nobody's going to answer your question for, your response for your request for help in the morning at this time. So better to hold off and take those steps that you kind of detailed out then is the idea. And so we've addressed some of these contributors to insomnia, like disrupted sleep drive and circadian dysregulation and arousal. So before we talked about relaxation and sleep restriction and cognitive restructuring as ways to improve insomnia. There's also something called stimulus control, which addresses kind of all three of these contributors to insomnia. And the way that we do it is by helping patients unlearn the link between bed and wakefulness and stress. There are some guidelines we follow. The way that we kind of break that association is by helping patients to avoid using the bed or the bedroom for anything other than sleep or sex. Those two things, nothing else. We ask patients to leave the bed and do something else if they're having trouble falling asleep within 15 to 20 minutes. So patients dealing with insomnia, they're participating in something that includes stimulus control. If they're falling asleep and it takes them more than 15, 20 minutes, we're getting into 25 minutes or more, they're asked to get out of bed, go do something else outside the bedroom, ideally. Something relaxing, not terribly stimulating, not too exciting, maybe read a book on the couch. But don't fall asleep. When you get groggy, and it may take a while, it may not, they'd be asked to finally then get back in bed and give it another 15 to 20 minutes. And if it becomes longer than that, then one would get out of bed and start the process all over. The goal there is to be awake and stressed and frustrated outside of bed rather than in bed. We'd also ask patients to avoid napping, maintain a regular bedtime and wake time. And then eventually, over time, using those techniques, the result is that the bed becomes a very strong cue for falling asleep, rather than a cue for being stressed and anxious. And so there's also, as I mentioned, there's these many contributors to insomnia, and there's individual treatment options that can address each one. But often we don't really know, in the context of a clinic where we're treating patients with insomnia, we don't really know whether it's mostly arousal that's keeping you awake at night, or the circadian issues, or the sleep drive, or these cognitive factors that might be a problem. So what we do is we just provide combined cognitive behavioral therapy to address all of these issues together at once. In addition to the stuff that we've talked about before, like cognitive restructuring and other issues, we also provide sleep hygiene. And these are kind of generic, kinds of things you might see in a handout at your doctor's office about how to improve your sleep. Make sure you provide proper opportunity for bed. Don't give yourself only 4 hours if you really need more than that, which most people do. Make sure you also provide a sufficient temperature control. So if it's too warm or too hot, you're going to be unpleasant and uncomfortable in there. And so make sure you get plenty of that. Make sure you provide plenty of opportunity for exercise, but not too close to bedtime, so that you tire yourself out, which can be helpful, but also is helpful for many, many other reasons. And then eat healthy foods, which is helpful again for many, many reasons, but can avoid foods that might be disruptive to sleep, like caffeine and alcohol and tobacco, which can also be disruptive to one's sleep as well. Wow. Now, those are the kinds of treatment options that your therapist, a psychologist or a social worker, perhaps a psychiatrist or others, might use to help you improve your sleep. That kind of therapy is commonly practiced throughout the country by individuals who can provide these treatments. But how do you access that treatment is what I wanted to discuss next before we answer some of your questions. So how do I get this cognitive behavioral therapy for insomnia, or CBTI? The way to get that is kind of difficult, or it was, especially before the pandemic. It was difficult to get near you. In this image from a research article that I published with colleagues a couple of years ago, we placed some gray dots around where there were lots of people who are providers of this kind of therapy, this treatment for insomnia. And we put blue dots around where the patients live, patients who are trying to get treatment for insomnia. And sometimes they overlap, but sometimes they don't, especially in rural states. So the darker the blue dot, the longer these patients had to drive to get to these treatment options. And so, it's not obvious that it's always nearby you. However, because of the pandemic, a lot of states relaxed their rules on who can provide teletherapy, that is therapy via video conference, and get reimbursed for it. And so it may even be that you can get this treatment from somebody in a different state, again via Zoom, and you can receive that treatment that way. But how do you find those people? The therapist near you, or not necessarily near you, is going to be easily found at this website, CBTI, or Cognitive Behavioral Therapy for Insomnia .directory. If you go to that website, you'll see something like this, where you type in any filters that you want to focus on, but you just type in a location that you want to zoom into, and you'll see a list of therapists who are enrolled in this website, which is an encouraging sign that they may be willing to take on new patients, and sometimes can do it via teletherapy, so you don't necessarily have to leave the home. There are also a few ways to do it on one's own. So these are apps. One is Somrist, another is Sleepio, that you can use from the comfort of your home. There may be some challenges in terms of how to use the treatment. Some of them may require, it's not terribly difficult, but sometimes some of them might require somebody to prescribe the treatment for you, but they can help you with that. Really, if this is something you're exploring, one option would be to just go to their website or use their app, and both of these have been shown to be very helpful. And this kind of treatment is helpful in patients and people who are survivors of cancer too. And so either of these I would strongly recommend. So that's for cognitive behavioral therapy for insomnia. I'll talk briefly about mindfulness-based therapy for insomnia and what that is and what it's about before we continue to some questions. One of the focus areas for mindfulness-based therapies is to attend on one's immediate experience. Rather than what came in the past, what will be coming in the future, patients are encouraged to focus on the here and now. We also encourage patients to be open and accepting of experiences. And so rather than being, kind of judging everything we see, which is very common for us to do, we can have this more relaxed and non-judgmental awareness of the present moment. That has the effect of reducing arousal, both psychological and physiological arousal. And then in practice, there are trainings, there are therapies that you can receive to provide training on mindfulness-based relaxation. And the way that this is helpful is, around sleep is to reduce arousal at bedtime and also reduce some of the distress that individuals feel due to being and feeling awake. There are other treatments available. In fact, I would recommend exploring, if you have the time and interest, a website called clinicaltrials.gov. It's a publicly available website where every single clinical trial going on throughout the country, maybe not every single, but many, many, many clinical trials, there's some exceptions, but the vast majority of clinical trials must be posted on this website. And you can search for insomnia. You can just type in insomnia as one of the keyword options and try to find a trial for treatment for insomnia that might be of interest to you. And some of them might be for certain racial or ethnic subgroups, or maybe for various treatment groups. People who've received treatment for ovarian cancer might be one of the focus areas here. Some of them might be online, and some of them may be medications. Often something to consider is a clinical trial, and this is one way to find them. I hope you all have enjoyed this presentation.